We got a few folks still kind of trickling in here. Um, see our friends Jeff and Parker. Erica's on. Shirley, I don't recognize your name. Shirley, where are you joining us from? I'm sorry if I should recognize your name.
Oh, I come from Taiwan.
Oh, great. Are you what's your involvement with extracorporeal therapies in Taiwan?
Uh, I'm in a local animal hospital, and I just graduated from the hemodialysis academy this year.
Amazing. Well, congratulations. That's an intensive course, and it's been so great to get everybody kind of brought up to speed with all the material and the direction in there. Are you in an active unit now? Do you guys have an extracorporeal program?
Oh no, I have not. I don't have the extracorporeal program now.
Okay, cool. Well, maybe some of the experiences that get shared in this group in these sessions may help as you move towards establishing a unit. So excited to have you. Thanks for joining us. Um, and then Jose, where are you joining us from? Maybe from the shower, like Dr. Calgill, unable to unmute. Well, when and if he's able to, we'll be curious to see. So I'm Jethro. This is the Extracorporeal Hour. This is an extension of a long-standing tradition of every other Friday meetings, led by our own Dr. Larry Calgill, who's on the call with us here as well. Myself and Dr. Cedric Dufayet down at the UC Davis group in San Diego are usually co-hosts here. He's traveling today, so he may not be able to join us. But in the spirit of what Dr. Calgill, built over the last many years of running these sessions, we've really continued in this tradition of trying to share our community experience in extracorporeal therapies, with the intention of highlighting some of the cool stuff and interesting pathways that other folks are venturing on in this realm, while also sharing our successes, but also sharing some of our challenges and some of the things that have been that we've learned from. And certainly along the way, none of us are perfect, and so this session is really meant to be an open forum for you guys to unmute, turn your cameras on. I'd love to see faces out there, so I know I haven't put you all to sleep. And more than anything, I'd rather hear more of your voices than anything I've got to say. I am Jethro, as I said. I direct our extracorporeal therapies unit here at Cornell University. I've been fortunate to have some great mentorship along the way in my growth as an extracorporeal clinician, but I'm learning as I go here. I've been a part of units in Seattle, built one in Connecticut, and then established ours here at Cornell a number of years ago, and continue to enjoy these conversations, building camaraderie and building our collective experience. Um, so with that, I went to our sign up list and I didn't see anybody with a case that they had wanted to present or discuss, at least signed up. So I don't know if there's anybody on here that's got an active case going, or has a recent case or just a general question, discussion points. I'll pause for a minute, which is sometimes hard for me to shut my mouth, and just see if there's anybody that oh, thanks, Jose. Jose's in the chat there from Mexico City. Appreciate it, Jose, for introducing yourself. And see if, yeah, is anybody got something active going on? I've got some interesting stuff to share in as a default, but like I said, my voice is more.
Hi.
Hey,
Uh,
Erica.
how are you?
Good, thanks.
We have an active case. We're treating it right now. My background is blurred. I could try to unblur it. Um, so we have a cat that we're treating for, oh, she's hidden. You can't really see her because we have her under a blanket, but she doesn't move when we have her like that. But it's a 1-year-old cat that was exposed to lilies on February 14th. This is her 16th treatment, so we're about 4 weeks into dialysis and almost 5 weeks into her kidney disease. But yeah, she's okay. We were hoping to transplant her, but she had some feeding tube complications. So right now she's on dialysis and maybe transplant in the future. What else can I tell you about her? She was anuric for 2 weeks, started urinating at week 2, now is uric. I don't know how polyuric she is, but she is urinating. She's at home now with an NG tube, which was kind of a first for us, but we pulled her E tube in preparation for trying to get her to transplant and clearing the infection, and ultimately sent her home with the NG tube, which is going great. So yeah, her creatinine today pre-treatment is 13.9. Her BUN is like too high to read. We didn't send one up to the lab. But yeah, she's doing well. She's on the Carpe Diem. We do anywhere from 6.5 hour to sometimes an 8 hour treatment. The Carpe Diem is just very, very limited in its clearance. So in a 6.5 hour treatment, we tend to get around a 70% reduction, sometimes a little bit better than that. But once we pass 6.5 hours, it's not like we get dramatic improvements from the 6 to 8 hours. Like maybe we get up to 75% clearance. So sometimes those extra hour and a half or 2 hours isn't really worth it. But she's doing well at home, and we keep hoping for additional kidney recovery.
Well, the first question that came up for me, non-extracorporeal related, was the date of her insult.
Oh,
Were
yeah.
Wednesday
It
flowers?
was the 14th. So
Yeah.
February 14th, Valentine's Day. We don't know for sure it was lilies, but it feels like a lily exposure. There was lilies in the house. She basically was sick immediately after the lilies entered the home. She went to a different veterinarian. I think the 14th was a Saturday. And so the 16th she went to, or maybe it was more like the 17th. She went to an urgent care clinic. They hospitalized her, noted she was azotemic. The owner had noted she hadn't urinated the whole weekend. And we started dialysis on the 18th. We struggled initially with her fluid overload, so she actually got 3 treatments back to back, and then we got that a bit more under control. But yeah, I think the big thing that's made a huge difference for us in her management when we've treated these cats before, and I'm curious to see what other people's strategies are, is we tend to struggle with the fluid overload as well as with hyperkalemia. So with her, we made like a huge diet change initially, and we put her on a really phosphorus and potassium restricted diet from the get-go. It's a human product called NetPro. And we worked with our nutritionist to add some protein to it. So ProCell, the taurine and arginine, to make it suitable for her. And I honestly feel like that made all of the difference compared to the past cats we've tried to manage on the Carpe Diem that are anuric. Just we've noticed in the past, like just a few hours post taking them off the circuit, their potassiums will be like 6 or 8 immediately. But for her, I do think the diet was, I think, instrumental, or there's something different about her. But we did manage her anuric for 2 weeks with every other day treatments on the Carpe Diem, which was a success for us.
Uh, Erica, you bring up a point that I often forget to remind people of, and that's when you've got a patient that you're treating long term like this, and I would say long term may be more than 2.5 or 3 weeks. You really have to supplement both dogs and cats. You have to supplement taurine and carnitine in their diet. Otherwise, they'll get typical taurine and carnitine deficiency um, complications. And they'll come on pretty quickly. So that's something that maybe is not generally articulated in the community, but after about 2.5, 3 weeks, then the diet definitely needs to be supplemented with those amino acids. You're dialyzing out a tremendous amount of amino acids during the treatment. That contributes somewhat to the negative nitrogen balance that dialysis patients get. But the taurine and carnitine are critical.
Yeah.
Erica, what's your catheter like for this?
Yeah, the like catheter god. So she has an 8 French 16 centimeter catheter in her right jugular vein. It was placed by our IR team with fluoroscopy. It terminates in her caudal cava. Uh, it's by a company called, I shouldn't tell them because they're all in back order and you guys all order them now, but they're by Mozark Medical. They're called the Marhakar catheters. I prefer them over the Mila. I think that they flow much better at lower pressures. Similar to the Milas, they do kink at kind of just a little bit distal to the insertion site. And kind of with her management, because we thought we were going to transplant her at the end of her second week, we stopped clopidogrel. So we did have, whether it was clopidogrel related or not, we did have some catheter clotting issues that responded quite well to TPA. But then she developed like a pretty significant kink at 2.5 weeks into therapy. So we ended up replacing the catheter with the same size, same side. We were trying to save her left side, and the left side was the one that had the E-tube abscess, so we didn't really want to go to that side. So we replaced it with the same size catheter, and this one has been in for a little over a week now, 10 days. And it's okay. It has a kink already. I just think these 8 French and the cat skin are so, maybe anyone else can speak to them. Their skin is just so movable that it's really easy for them to kink, even when we do our darndest to keep it in the right position between treatments. The other thing that was interesting about this case that I don't have a ton of experience with is she had a pretty significant contact reaction to chlorhexidine. So she developed a really significant dermatitis around her neck that it took us a while to kind of figure out what was happening. She developed a lot of crusting. Ultimately, we, consulted with our dermatology team and they were concerned for a contact reaction or they were concerned she might have a pretty severe pyoderma because it got pretty bad. But as soon as we eliminated chlorhexidine from her regimen and we switched to iodine to kind of clean her insertion site, things have been improving dramatically. But there may be some underlying skin disease in this cat because she's just like kind of itchy all of the time. But that was a new thing for us.
Interesting. What are those polyurethane catheters?
Yeah. Yeah. Yeah.
Yeah, our silicone ones have like these labels all over them. I know you guys, I'm speaking to the choir here, that say don't use iodine anywhere near them.
Yeah.
And so that was an interesting.
Yeah, we were like freaking out at first. We're like, oh my gosh, what are we going to use? And then thankfully the manufacturer publishes, what's acceptable to use on the catheter and iodine is okay. But at first we were like, oh my gosh, we can't use iodine either. What are we going to do? But thankfully, because it's a polyurethane catheter, we're able to use it. Yeah.
We used iodine on silicone catheters for decades until they came out with that. Apparently, the iodine causes some etching, but I think even on short-term dialysis, you're not going to have any problem with the iodine. I don't think the silicone material has changed from what we started in cats using silicone catheters because it was the only 8 French catheter that was available back in the 80s or 70s or 80s. And but I would just echo, we don't even stock or didn't stock polyurethane catheters except for toxicities. We get one shot with them and then that's about it. So
yeah, shockingly, these catheters work pretty well. I had this catheter in a different patient for 2.5 months without problems. So
I think I think
I was impressed.
smaller size ones do better than the bigger
Yeah,
size ones, but you get
makes sense.
an 11 or 12 French polyurethane catheter and it's going to kink on the first treatment.
Yeah, I mean, it's not our preference, but I don't like the Milas, which I think are polyurethane as well. So we found these other catheters that we seem to like. They have their same problems. So
I still, all this discussion still take, I still have this old geriatric schnauzer with grape toxicity, AKI, that we dialyzed for 3 weeks. And at that time, as a resident, my job was to keep that kink straight throughout the course of her treatments. And she was blind and a little bit deaf and very senile. And it was just like that polyurethane has its other, bad memories for me, but that's one that'll always stick. Um, do you mind telling us about your TPA approach for this catheter?
to salvage it. Yeah, we basically just get cath flow and still it comes in a 2 ml vial, basically 1 milligram per ml, and we just instill. One time I just instilled it into each lumen for about an hour, and that re-established patency. But I've also used it as a lock, and that worked quite well as well. So I just locked it with TPA, and then at the next treatment removed it. Is that what
And
other people are doing? Yeah. I think it works quite well to reestablish flow. It has not yet failed me. I don't know what other people's experiences are. But it's worked quite well. It's just expensive. It's like for us around $200 each time we use it. So I guess it was cheaper than replacing it. But if you have to do it repeatedly, it may make sense just to replace it.
Carolyn or Dr. Cowgill. Carolyn, are you there? Do you guys use TPA to reestablish flow in your catheters sometimes?
Hey, Jethro. We actually don't use TPA. Sorry, I signed on late. I was at the dentist. We don't use TPA. Um, we've never really, so far, knock on wood, in the last few years, we've never had one that we've not been able to get flow going again. So, we've had to replace one catheter, but otherwise, I can't think of us having to use TPA anytime recently.
Okay. Dr. Cowgill, over the years, you guys have probably instilled a fair bit of TPA.
Actually, not too much. I used it a couple of times again in the olden days, and I keep hating to harp on the olden days. Before TPA, we used uricase or there was some other product that would do that, and that one was kind of nasty, but it worked. And Dr. Langston's the one that sort of introduced us to that, I think, and she's had good success with it. I think that it probably does. It's a good opportunity and a good mechanism to try and clear these clots out, the intraluminal clots out. And then it may, if you put it in and still it may get some of the clots that are around the pores potentially. So I think Erica's right about this.
Yeah, we use them if you have I think it's a nice, what is that word I'm looking for? It's a nice something to put in your toolkit, because even with triple lumen catheters that the lumens fail, but you don't want to replace it, it can be a nice option. Our critical care team has pretty good success with it in that aspect as well. It's just expensive, too bad, that it costs money.
Well, now it comes in these concentrations and volumes that are designed for catheters, and it used to be that you had to buy a systemic version of TPA that you would use for an intravascular clot, and that was a little more expensive and a little trickier and a lot more wasteful. But I think the catheter-based solutions are probably, I would agree with you, it's probably something you ought to have in your unit. What's the expiration? Does it last a reasonable time?
Once you reconstitute it, you're supposed to use it within.
I mean the shelf life. Can you?
I'm
Is
not
it
sure.
lyophilized? Is it lyophilized?
I'm not sure. You definitely have to reconstitute it with sterile water and then use it pretty quickly.
Erica, something else you said there. I had the question that came up for me as well with the course of things. You talked about using it as a lock one time as well. I wondered, kind of in the background of that, if what is your typical locking solution, and how did it change in the face of this catheter clotting out? In addition to that looks like a single time you locked it with TPA.
Yeah. So typically in cats, we lock with the TCS, so the citrate. I had one cat that I locked with heparin and had a GI bleed between treatments, so I just am a little gun shy now, but I have locked this cat with 100 units per ml of heparin, but the TCA seems to be working well otherwise. So the torlidine citrate, TCS, I should say, TCS. The torlidine citrate that you can get from Norfolk Vet, I believe, is where we get it from. Yeah. What else can I answer? And then, the one time I locked with TPA, I guess it's something that they do with not uncommon frequency in peds and pediatric patients. We have a connection with our children's hospital here and just have had conversations about catheters and clotting and all the things we were talking about. And they will lock people with, kids with TPA if they're really clotty.
I might make two other comments. One is, so is this catheter using, is it an intravenous catheter or is it a dialysis catheter specifically?
On this cat, it's a
Yeah.
dialysis catheter.
Okay, good. Sometimes, if you're using a dual lumen intravenous catheter, the ports are so separated for the inlet port and the outlet port, and you get flow through the side holes out the end, and often you'll get a big clot in that segment of the catheter because it flushes all the heparin out. Maybe the other caution that I'd based on what you said is you've got to titrate the amount of heparin that you put in your catheter according to the size of the patient. And I would usually use a 200 unit per mil heparin in a cat, and I think 100 unit per mil is, unless it's a teeny little cat, maybe wouldn't be enough. But you start getting more than that, and the heparin leaks out of the catheter, and you can systemically heparinize an animal, dog or cat, to the point where they could bleed. So it has to be proportional to the size of the patient and how clotty the patient is. If I've got a patient, we're putting in 1,000 unit per mil heparin, and the dog clots clots reasonably, or we get a big worm clot when we do it. We'll go up to 2,000 or 3,000 unit per heparin in a bigger animal.
Yeah. So she's pretty small. She's down to 2.6 kilos.
Yeah.
And so 100 units per ml made me more comfortable. If I had to bolus that, it would be like her bolus dose of heparin. I think it would be like 50 units per kilo or something like that. So I was reluctant to go much higher in her, hence why we just use the citrate instead, because we feel a little bit safer with it.
Yeah.
Yeah, I like what you just said, Erica, there, because that's kind of how I think of it too, is what would that dose be if all of this got sucked in? And could I live with that? Knowing, considering the half-life of heparin and the rest of that, what would that do? And so that's part of how I reason my concentration as well. And then to Dr. Calgo's point, also sequential catheters, how well are they doing with the low dose that I've started with, or whatever dose I started with, and then adjust, based on some of those factors too. That's awesome. I am working on my end here on a lower volume type of platform, and I've certainly done my due diligence investigating the Carpe Diem, and like you said, though, it's that extended 6 hours at a time there, just due to the inefficiency of it. The other platform I've been looking at, and I was hoping Chap or Dan Gordon would hop on it at some point here. I need to reach out to those guys, but the Aquadex is an ultrafiltration platform that you can utilize that convective clearance in a kidney replacement type of application. I don't know that it's any different efficiency wise compared to the Carpe Diem, but that's something I've been curious about. I don't know if anybody's had experience with it.
Not with that.
Yeah. I
There,
was just gonna say, I don't have the Aqueducts, but it might be worth reaching out to your local children's hospital because our children's hospital has the Aqueducts and they love it. They have the Carpe Diem as well. Um, so yeah, they might have some insight for you. You're right, Shap does have it, but I don't think, just in my conversations with him about the Aqueducts, I don't think that they're using it routinely. Like it's in a closet and they use the Carpe Diem. Yeah.
I think they got it.
there's a
Did it
there's
second.
another company. So I pretty regularly when I go to the apheresis meetings, Medica has these are human meetings, and Medica has a slate of machines that they have out there, and they have a machine. It's not the VetSmart. Don't ever buy a VetSmart. That machine is a piece of junk. But they have some machines on the human side, which I think would be excellent for veterinary medicine. I've told them about it. I don't have the brochures in front of me right now, but that might be it. And they're trying to get approved in the United States on the human side, and that may have happened already, so that they would have machines and they would have technical support in the U.S. But I think that their machines would be worth looking at. They have a machine that you can put a variety of different circuit sizes on, and it will do all the modalities. It'll do dialysis, it'll do perfusion, it'll do plasma exchange, CRRT. And again, it's the human machine, not the veterinary machine. But it looked really nice to me. And Jethro, I can put you in touch with the man who, because he just sent me an email the other day that is trying to get it distributed in the United States.
Well, that'd be amazing. I like the versatility that you described with it as far as different applications as well. Because I think the Aqueducts you're confined to just the convective type
Yeah.
of.
Yeah, I will say the Carpe Diem's a lovely machine. It's really easy to use, to teach on. You can do plasma exchange on it. So for those little guys, you just have to get the filters from Italy. It's a really elegant machine, and the customer support is quite good over the phone. It can take them 24 to 72 hours for a service call, which is not great. They have to send technicians from other parts of the country sometimes because I don't think they have like a huge number of machines out there, but I do like it a lot other than the long treatments. But
And the cost, $80,000
yeah,
is a pretty dear cost for a dialysis machine.
yeah, and the treatments are definitely more expensive because of the cost of the machine and the cost of the circuits compared to our intermittent platform. But like this cat is 2.6 kilos, and even on the smallest circuit from the Carpe Diem, it's 21% of her blood volume. But I guess the nice thing is we can get away with like half a unit of blood for each treatment rather than like a full unit of blood. So her PCV is like 19. She's on Darby now, again, because transplant has been pushed off. But we basically do a half unit of blood and a half unit of plasma for each treatment. And she tolerates it very, very well. I think it make me nervous to put her on the Blue Star, although we'd get a really efficient treatment. I don't think she would tolerate it well at all. And these cats just really do tolerate the Carpe Diem very, very well. You can't put the other thing as a downside is the crit line. So you only can put a crit line on with like their bigger circuit, the 42 mil circuit, but you can easily put it in there because there's a DIN connector. So that's fine. If you really want a crit line, you can put it in, but I don't know. I think sometimes with cats, this is Dr. Cowgill, don't yell at me. But I think sometimes with cats, the crit line can be distracting because their values can be scary compared to a dog. And so sometimes I think I'd rather not have it sometimes if you're trying to really ultra filter a cat.
Yeah, well, the flows are probably pretty small, so that would be a risk putting a crit line in there too. And you'll get streaming through the chamber and clotting, and I'm not yelling at you.
Okay. No, I was just saying of jumping the crit line, but like the crit line when we put it in hasn't clotted, and it's it's obviously helpful to have that information, but yeah, we don't have a crit line on her today, but she's not overloaded anymore, so we don't really need it as much.
Erica, he's not mad. He's just disappointed.
No, I'm not in the
I'm
least.
joking. I'm teasing. I
I
guess
wouldn't treat a cat without a crit line, but you can go ahead.
My motto is make their blood black, but you probably don't like to hear that either. Oh my
Yeah,
God, look at
well,
his face. He freaked out.
yeah, well, I mean, the normal O2 sat in those patients is about 45 or 50, and that gets kind of scary. And
Yeah,
that's with a good one.
I know. I know. But I think that's where I find the crit line.
Although I think the new crit lines don't go down that low. I think they stop at about 50, don't they? They
No,
don't. I
I
don't.
think our crit line will go. It's going down to
Will it go all the way
gone down
down?
to like 30s. Yeah.
Yeah.
I've seen it down there. Um, yeah, I think oh shoot, there was something else that jumped out at me there as well. And I forgot what I was going to ask you about. Carolyn, did you have any experience that you wanted to share? You had put in the chat that you guys like your Carpe Diem. Oh, that was it. The last time I tried to price one out, it was more like 110K. And that was a couple of years ago. So I think the price may have climbed from there. But yeah, Carolyn, I saw you unmuted there for a second.
Oh no, I was just going to say we actually really love our Carpe Diem. Um, we do put the crit line on when we use the 025 kits, just as a matter of fact. But it is so precise. Those scales are calibrated so well that unlike with the Fresenius, where there's question as to how much ultrafiltration you're really doing because you're sending it into the sink. There's that kind of plus minus maybe 10 to 15%. With the Carpe Diem, we know exactly what we're ultrafiltrating. So, if you're asking it to pull like a mil an hour, that's what it's pulling. So we don't worry as much using the smaller sets on the Carpe Diem about that because we know exactly what it's doing. And just for Erica, I don't know if you know this, Erica, or not, but in Italy, apparently you can now get an 0075, which has a total priming volume of about 15 mils of the whole circuit. Yeah.
Wow.
We've been trying to figure out whether or not we can get it here, how we can get it here, but it took us over 6 months to get everything set up to get Plasmart filters, the TPE filters. So I'm not sure whether or not we could get those shipped here.
Yeah, it took us 6 months too, but our second shipment was way faster. So maybe it's just the initial setup for the Plasmart filters and then it's improved. But that's really cool about that. It's a smaller circuit.
The dialyzer is again smaller, and then I think the circuit's a little bit smaller as well. But I had been speaking to the technician, and he was telling me that over in Europe they have like an 0075 that has an incredibly small priming volume.
I can't even imagine how long we'd have to treat on that though. The clearance is probably even worse, right? Oh my God. You have to move in.
Carolyn, we were talking about catheter locks as well there. What do you guys have for options up at Tufts? What's your go-to?
We typically use heparin. Mostly we use heparin. There was a paper out a whole bunch of years ago. It was almost a one-page abstract from a group, a hospital in Brooklyn, where they use bicarb because bicarb chelates calcium, and being alkalotic, it inhibits biofilm. So we tried using bicarb. We did a little pilot on some beagles, and we found that it works. It seems to significantly prolong your ACT. I guess the short answer is every now and again with animals that may have some sort of coagulopathy, may have a low platelet count, we'll actually instill with bicarb, because if I have to inject that in and flush it in, I know that I'm not going to cause them really any detriment whatsoever, versus if they're already coagulopathic and I have to flush the heparin in, I may be giving them a significant amount of heparin on top of an animal that's already coagulopathic. So oftentimes when we've got those animals that are kind of on that edge with the bleeding risks and so on, we'll actually just use bicarb.
What kind of a concentration are you putting in the catheter?
8.4%, just straight
Okay.
bicarb.
Uh-huh.
And then
And how low does it drop the calcium?
it we didn't actually check the calcium on when we did our little pilot study. We looked at ACTs. But that would be actually something to ask. There was a paper that came out from a group of hospitals in Southeast Asia last year, where they did a blinded study of heparin versus bicarb. The paper came out last year, and they showed in humans they were using bicarb, and in that study, and they showed the efficacy of using bicarb that way as well.
As a catheter lock.
As a catheter lock.
Yeah. Well, that's great new information.
You know, I get these emails. Somehow I ended up on an email list for something called Torolock, which is I think it's a combination citrate antimicrobial lock. And I know, Calgill, you've talked about using antimicrobials in your locks historically as well. Is there anybody out there still adding antimicrobials in their locks?
I think our group is still adding cefazolin.
Yeah. Just another interesting variation for folks that you know don't have that background. There are a number of different ways to do this, and I think we're still trying to figure out. I think to Erica's point about knowing different tools in your kit, referring back to the TPA as an option, these are all different strategies to kind of think about how we might try and prevent clots in that catheter and maintain patency, because it's definitely the lifeline as we all recognize. Erica, to keep you on the spot for another minute, I may try and steal 5 or 10 minutes at the end to show some full work we've been doing on this side. But you talked about your darbepoetin in this cat. In terms of choices wise, and this is going to come from an ignorant place as well, but I know a lot of folks are using meligostat in more of a CKD application in these guys. Did that come up in conversation or decision making in this case, or was there a better choice?
Yeah, the only reason we do Darby is because that's what we stock. We don't stock the FDA approved for cats liquid. But yeah, I don't know. I'm curious to hear what other people would do if you had a choice. I just didn't have one, so we're doing once a week Darby. We did it.
Yeah, I mean I'm kind of in the same boat as far as what I've got access to, so that would probably have been my choice as well in that situation. But I don't know, Carolyn or Dr. Calgill, do you guys know if folks use meligostat in these types of applications in the cats? I think it does, if nothing else. I mean, this highlights for folks that aren't doing a lot of this or are learning and growing, that we have to support their red blood cell mass in one way or another, and they do develop this anemia of chronic disease, even though this cat started off healthy and otherwise fine before. Erica, the other question I had for you real quick is curious around, I imagine the answer being a criticalist in all this, are you cross-matching this cat every time?
Yeah.
To your, yeah.
Yes. So what we do, yeah, we cross-match prior to every treatment. So hence why we just got started this morning at like 10:30. She comes in, we draw a purple top, and then we cross match her to the unit she already bought or to a new unit. Just to let you know, I think we may be stopping dialysis today, just mostly from a financial perspective. Her bill, if you guys can believe it, was like she spent $80,000 on the first hospitalization. And she was in the hospital for 3 weeks, and she's been outpatient for about a week. And not surprisingly, they are tapped for money. So it's like this debate that we're having too about, can we support her off of dialysis, reduce her red product needs, keep her alive until they can save more money to transplant her. I think it's unlikely. It's hard to know how much renal recovery she's having, but based on a few cases that I'm aware of, there, I think Jawang is not on the call, but he's trying to put together a multi-center study of these Lily cats that required renal replacement therapy. And just from the few cats we've had at Penn that have been survivors, like their creates, maybe if they have good recovery, are in like 4 to 5 range for the anuric cats, which is not terrible. But I don't know with her if she'll recover to that point, or have no additional recovery beyond what we're seeing. So it is challenging from the money side of things. Like, had we, in hindsight, I think we have learned a lesson here, since we have access to transplant, to not put an E tube in, just put an NG tube in and try to transplant as early as possible, because otherwise we spend so much money on the dialysis part of things that then they run out, and it's sad. Yeah.
Do you have some sense, without giving away like insider information, what the cost of a transplant is?
Oh yeah, it's like I think they're quoting 25 to 28,000, and like we quote 20,000 for the first week of dialysis. I guess I don't know if we can talk about money on these things, but probably we should. I don't know the whole, I don't know.
Yeah.
Yeah. But the Carpe Diem treatments, just because the machine itself is expensive, she requires blood products, it adds up. It's like in 2 to 3 weeks, it's the cost of a transplant. Well, more. Yeah, I mean, we basically have bought 3 transplants with her care so far, which is just feels like, ugh. So hopefully the owners can save up some money and transplant her if we can kind of support her to that point.
Well, and I mean, I guess I don't know I do have somewhat of a heart. I mean, part of it would be, maybe there could be some recovery without needing to get to the transplant. But to your point, I guess we need some of that data that you're talking about, trying to gather multi-center wise. Does it make more sense to cut to the chase rather than dialyze for a few weeks, spend that money waiting to see, hoping? We need some data on that.
Yeah, my impression from looking at Jawang's database, and I don't have all of the data, is the ones that are anuric just take a long time to recover, like weeks and weeks. Maybe Dr. Cowgill could speak to this, but like weeks and weeks of treatment. Like we had a cat from 2013 that was dialyzed here for a month and then did get a transplant, and then had an anaphylactic reaction. It was like crazy. The story is crazy, but ultimately thrombosed his allograft and was explanted at around 2 months post Lilly exposure. And at that point, he had native kidney recovery, where his creat was like 5-ish. And that's where he hung out for years with a creatinine of 5. So he's the one we always go, like, maybe after 2 months, maybe your creat will be 5-ish. But yeah, I do think we need to get the data out there from all the centers that have treated these cats long term. I would say a huge number of them die early in their hospitalization from fluid overload and hyperkalemia. So we feel like it was a success to get past that point and kind of to where we are now, that, gives her a chance for some kidney recovery.
In the days when we were doing transplants at Davis, we would really recommend you get them to transplant as soon as possible, because if you start them on dialysis, you've got 2 big risks. One is the dialysis catheter, one is the feeding tube. And if those patients get an infection, then it's toast. And it's pretty common for them to get an infection in either of those invasive sites. So, you might have to treat them a few times just to get everything prepared, but get them transplanted as soon as you can.
Yeah,
Before you get
that was our goal, but we had the exact complication you mentioned, that E tube complication. Like week 2, she had this like intermittent fever And we were like, what is it from? And so ultimately at the end of that week, we were trying to transplant her that week, but then we detubed her. We pulled the feeding tube. We pulled everything that we could. And we tried to immunosuppress again. And then she got an abscess at the E-tube site that had been pulled. So it was just really frustrating. Because at that point, yeah, our transplant team was like, no, not right now. And then the owners are like, we're running out of money. Yeah.
Our transplant team, it was almost a given that if there was an infection, the cat would never get transplanted. They softened a little bit, but it took about 3 weeks to resolve the infection and re-challenge them before they would agree to do it. But it was a death sentence if they got infected.
I would say the same here, but she's still alive. Maybe we can get her
on dialysis. Yes, dialysis.
Yeah, maybe we can get her. Maybe we can get her to end of May or something, and she can have a transplant then. I don't know.
With what you said, my E-tube and dialysis catheters, both potential knives for infection. Do you guys leave the dialysis catheter in during the transplant, or does that come out as well so that you're reducing risks?
Usually, the cases we've treated before that have been transplanted will exchange the catheter for a triple lumen because they usually need all of those ports for blood sampling. And thankfully, no transplant cat has needed additional dialysis that we had to put a dialysis catheter in or go to the other side. But
well, oh gosh, I hope you guys have obviously invested a lot of yourselves in, what's the cat's name?
Queen, she's perfect. She's from Russia. She's a Siberian. She's a really good cat, so it's kind of heartbreaking, but yeah.
Well, she's obviously gotten a lot of care, compassion, and amazing medical support from you guys. So I've got my fingers crossed in the background that whether they find that source of income and she gets stabilized or has that renal recovery that you've seen a couple months down the road after a transplant, taking the kidney out again, that would be amazing if we got her there. But thank you for sharing all that. That's awesome.
Sorry for taking over. I was just like, hey, we have a cat.
I love that. No, that's perfect. Like I said, I'd rather hear your voice than have me ramble on. So I'm not nearly as interesting. But I do have, if you guys are okay, unless there's any last comments, questions about Queen from anybody else who hasn't chimed in yet. Let's see if I can share my screen here. Let me see, where did PowerPoint go? There it goes. All right, I've got something. Feel free to jump in whenever you want here. It's a little bit of a longer one, so I'll probably just cut to the chase with the one that we're doing now. We did treat, this was Sweet Pea, a 2-day-old mini horse who was septic from pneumonia, failure of passive transfer, and had a septic joint. We did hemoperfuse her. This was a few months ago, and we're just in the midst of revisions on the case report. So maybe I'll present her another time so that we can show you the one that we're treating currently, or we treated last night here. And as you guys in the extracorporeal world can attest to, it's almost always when something else is going on. We're in the midst of our annual cardiopulmonary boot camp here at Cornell, geared towards criticalists and third-year residents. Continue to share. And it's an intense 4-day, and being on faculty, I'm one of the instructors for it, intense 4-day conference for these guys. And it never fails. Last year at this time, we had a really bad IMHA that ended up needing treatment, and I had to duck out and find a replacement for me for part of the conference. And this year is going to follow suit. I need to stop signing up to be part of this conference, maybe. But this is a foal that presented to our large animal hospital 3 days ago now, the day after being born. He's a warm blood who was a full-term gestation, normal pregnancy, gestation period, everything else was totally fine until he was born. And it's a little bit sketchy in terms of that. The woman owner, I think, or barn hands was there when he foaled. and reports that he was not breathing at the time he was delivered. And so she did mouth to, I guess that's a snout, mouth to nose, respiratory rescue breaths until a local vet was able to come by within a short period of time and administered epinephrine to the foal. Got his heart rate up and going, and then they transported him to our equine and farm animal hospital here at Cornell. I promise this isn't me being callous, but everybody on that side of the hospital calls him a dummy foal, so I'm going to adopt some of that language. But he suffers from hypoxic brain injury, and so he's pretty uncoordinated. He's not suckling. He's flopping around. This is him standing, obviously here, but this is after 2 treatments. With hemoperfusion, which we'll get to. So pretty significantly affected. Going in his favor, they did give him hyperimmune plasma. And so he has white blood cells. He's not currently septic. So we've got that going in our favor, but he was recumbent, again, mentally inappropriate and not very functional as a living being. He's about 62 kilograms. So we had a discussion around the utility of hemoperfusion for him, and though there's certainly a lot of the work done on the septic patients and cytokine removal, we thought about him in terms of his hypoxic brain injury and the potential cytokine storm, ischemia reperfusion injury, and potentially some of the targets that we might be able to collectively absorb down those pathways. And so we met him the day after. So he came in the day he was born and had his respiratory arrest situation, all the rest of that. That night they reached out to us, and the following day, see if I can advance my slides here. We decided to go down that pathway of hemoperfusion, knowing that some of these foals, I'm told, can make a reasonable recovery. Maybe in the 60% chance of making it through. And so we set out, as we often do in some of these cases where we're learning and growing the knowledge base and the application base of recognizing and pointing out to the family, we don't know if this will help. Sure, there's some potential downside with anticoagulation and extracorporeal circuits and some of those things that go along with any of our therapies and modalities. But I've really kind of softened a lot of my discussion around those because I've scared a few people off. Just talking about the normal routine things that we manage with any extracorporeal case. And this guy being 62 kilograms, we had a little bit of leeway in terms of our circuit size and blood volume and all the rest of that. And so we decided rather than wait until he was looking worse and worse, we would go down this pathway while he was just kind of, treading water, I would say. And so the first night, which was 2 nights ago, we waited till the end of the conference. Then my large animal colleagues placed a 14 French 30 centimeter silicone Medcomp dual lumen dialysis catheter in the right jugular. It is in the caudal vena cava on this kid. And we decided that just practically speaking, we were going to target about 2 hours of treatments, which worked out to be about 5 blood volumes. And at the end of a long day and everything else, that was just kind of a practical decision for us. And so we looked at our 2 hemoperfusion options, and certainly the Cytoclear carbon device is gaining a lot of traction in terms of cytokine removal, and we've got our old friend the Vet Rescue synthetic polymer bead device as well. We ended up going down the pathway of using the Vet Rescue and the Purify platform. And our extracorporeal circuits, we use the biggest Vet Rescue column, 300 mil of beads, and between that and the circuit was about 220 mils, give or take, which was in this foal 4% of its extracorporeal blood volume. So really not too significant of an issue for them. We that first night did treat for, like I said, about that 2 hours. Processed about 25 liters. His blood volume is about 5 liters. And this was him just before treatment, actually here, down, recumbent. He's not sedate in this picture at all. Here's the mare standing over him. She's pretty protective of him across the barrier there. And after that couple hour treatment, certainly with a lot of support, but he was certainly showing some clinical signs of improvement. We don't have any immediate biomarkers. We've got some cytokine panels that will be submitted, so we don't have a lot to say kind of on that level as far as improvements that we made. But clinically, he seemed stronger. He was up and around, and the following day, he was up on his own without all this support for a little bit. But he did have some mild setbacks, and he became a lot weaker, was recumbent more of the time than not. And so last night, we did decide to do a second treatment for him. And so very similarly, we treated for about 2 hours on the Vet Rescue platform and the Purify platform and the Vet Rescue device, similar circuit volumes and the rest. And this was him. This was with a little bit of sedation last night, but post treatment and today. Oh, this is my view. This is the mare. I was down by his head most of the time, managing the kind of the circuit, the line, and being able to reach up and access the pump. The other challenge in these guys, because he is so uncoordinated, if he were to get up and move around, we're going to have to provide a little bit of restraint / confinement. And I was ready with my hand on the pump to move it and follow the dummy foal around if he was thrashing, which he didn't end up doing that night. But Mom would frequently look over at me and be chewing on some hay. And I think folks have some good pictures of me like protecting the catheter sites as she's like dropping hay and drool and stuff over my head and over the catheter site as she's trying to check on her foal. So just added a little bit into the mix there. The foal was hyperbilirubinemic, and so this is a little bit of that bilirubin extraction that occurred in. This is the second treatment, the second column, and this is the video they sent me today. Let's see. So up and around. One of the things that we did through the course of his treatment is kind of test his suckle reflex. So just as a I don't know, weak, subjective marker of some kind of clinical improvement, I would, test his suckle reflex just digitally in his mouth. And at the start of treatment and before, he was limp, nothing, no response to that. And pretty significantly through the course of both the first and more so the second treatment, he had a pretty robust suckle reflex and was really working to try and nurse. So as a soft finding, just clinically speaking through the course of this short treatment, short and sweet, but I was seeing some clinical improvement that way. And this was him just a little bit earlier today. So I think unless anything changes with him in the downward, that was going to be something else, as a backslide, I think we're not going to treat him tonight. Not really knowing what the right answer is. There's certainly some financial limitations in all of this as well, but I think we've made a good improvement clinically speaking. We're going to reevaluate that tonight and decide if we think a third treatment might be indicated for him. But we're pleased with the outcome thus far. And I'd be remiss if I didn't, he's on the call here, didn't shout out to Parker, our vet rescue friend, for helping resupply some of our equipment last night, driving up from Pennsylvania for us, so that we had what we needed and to hang out for the treatment. Taught me a few tips and tricks with the device. Yeah, happy in the last minute or two to open the floor to any questions or comments around what we did or why we did something or didn't do something. I know I didn't get into all the details of it in this short period of time. One of our interesting challenges that we're working on in these equine models is, and we are doing some work with the Carbon team looking at an equine model as well, is the anticoagulation strategies in these patients has been an interesting adventure. They sit with a higher than cats and dogs baseline ACT. And so looking back through some of the literature on equine ACT targets, we've actually been working through is it twice baseline? There's some other literature and some other anecdotal reports of targeting an ACT up in the 700s. One of our other foals that we treated had some issues with bruising in the period after treatments. Carolyn's going to come down and join us for one of these treatments. That would be so much fun, Carolyn. We'd love to have you. Yeah, that's been one of the other really steep learning curves with us, as well as finding that balance of flow and not clotting out our devices, along with figuring out where our targets for heparin and ACT targets are in these foals and in our adult models as well. So it's been an interesting adventure, and we're looking forward to sharing some of those results as we start learning more from them. Well, between Erica's cat, which was so much great conversation around that, and my brief show and tell here with our foal, who I'm not sure if the foal has a name yet. Mom's name is Bellini. So the foal is currently in our medical record system as Bellini 26. But I think we're working on getting the foal named, seeing as how his trajectory seems to be moving in the right direction here. But I'll keep you guys in the loop if we treat again and what his ultimate clinical outcome is, and try and get that out to the group in another one of these sessions. One of the cool things, and then we'll wrap this up. I've been fortunate enough, we're certainly still growing and building out our small animal extracorporeal units and blood purification units. But I've got a great partner on the large animal side who's a criticalist internist, and she's driving a lot of our efforts to get our large animal team more comfortable, aware, and maybe thinking a little bit earlier in the process. We have treated a cow and another septic foal, but I think with hemoperfusion, but we got to those patients, on death's door essentially, and so it certainly doesn't help to raise the confidence level or the interest level if our patients fall off the dialysis catheter or the extracorporeal catheter, as soon after or early on in the course of treatment, when they're already that far along and that far decompensated. It's hard to build a culture of comfort, interest, and confidence in these applications in a new population and a new group that doesn't have a lot of the awareness and knowledge base that our small animal colleagues have. So it's been great to have a partner on that side of the hospital for sure. All right. Well, with that, it's 12:03. So this session is recorded. We've got that available. It will be on the ACVNU website. I think shortly after the fact here. Just as a reminder, we have a sign-up sheet that's available also on the ACVNU website. If you've got an interesting case, if you've got a clinical question, or you want to just highlight some of the work that you're doing, good, bad, learning opportunities otherwise, and want to just give us a heads up that you want to bring this case so we can help prep for it ahead of time. That sign up is available on the ACVNU website under, I think it's still /IRRR. But if you get on there, the sign up sheet is there. And Cedric and myself are always happy to chat ahead of time to kind of set the stage for your case or your topic. But come with a presentation, come with just a conversation like Erica's today. That was perfect. And we'd love to see you at the next session in a couple of weeks. Thanks for everybody's time, interest, and contributions today. This has been a great discussion. Erica's maybe disappeared to help and take care of Queen in the background, but do you want to close this out with a final word?
I don't know what to say, but it was fun. Thanks for listening to our story about Queen.
I learned something every time you come on board here. I learned something new. So thank you so much.
Oh, I learned so much. That's why I try to come whenever I can.
Amazing. Well, everybody have a great Friday and going into the weekends, and happy blood purifying wherever you may be or whatever stage you're at. And I've got my fingers crossed for Queen. Hopefully one way or another we get somewhere, and at least she's had more extra time than she would have otherwise. So if nothing comes of this, then that time I still consider that a success, whether it's a couple of weeks or a couple of years, whatever it ends up being.
Thanks, Jethro.
All right.
Thanks,
Thanks.
Jethro.
Take care, guys.